How's it going, everyone? Tom Walters here from Rehab Science. I am starting a new lecture series here. This will probably just be 3 parts. I may do more depending on people's interest, but in the past, I did a lecture series where I covered the basic biomechanics course that I taught for undergraduate kinesiology students. So if you haven't seen that and are interested in biomechanics, make sure you check out those lectures. You can find them under my biomechanics lectures playlist on my YouTube channel. This pain science class was another elective type course that I taught to kinesiology students. And, while there are a number of lectures, I think this first one is really the most useful, and I've broken it up into 3 parts. So let me know what you think about it. If you want more information on pain, I could do the other lectures too. But just want to start here and see what people thought about it. So pain is something that's really interesting to me. It has been for a long time, primarily because there are so many myths and sort of outdated ways of thinking about pain. So many practitioners, whether it's from medical practitioners and even a lot of rehab practitioners, I think this is getting better as years go on. And the longer I've been a physical therapist, it seems like this is getting better. And pain science information is sort of infiltrating the practice of more and more practitioners, but we still see a lot of practitioners that operate from sort of a older, outdated, postural, biomechanical, structural type of framework when thinking about pain and injuries in the human body. And that's the way I started. I mean, it's the way a lot of us were trained in school. And as we look at the research and how pain research has changed over the last 10 to 15 years, I think we really, as practitioners, need to change and think about all of these different factors that can influence pain, not just our physical body, our biomechanics. Sure, that can be an element. The tissues of our body are an element, but we have to think about these other factors that have been shown to be associated with pain. And that's what I'm going to cover in this lecture, and hopefully you'll go away from this. If you're somebody in pain, it will maybe help you think about your pain from a more comprehensive standpoint. A lot of times people who are in pain, because medical and rehab practitioners haven't explained some of these things to them, they aren't paying attention to other things in their life that could be contributing to their pain state. So it can be helpful if you're in pain. And then if you're somebody who works with people in pain, maybe you're a trainer or you're a PT or a chiropractor, same kind of idea. Hopefully this will give you some tools and maybe a little different framework for looking at people who are in pain, and how you listen to them, and maybe what comes up in your conversations during your sessions. Maybe it gives you some other things to teach them about, and hopefully can help them focus on, again, other aspects of their life that could be contributing to their pain. And a lot of times we see that addressing some of these factors can help people lessen the risk that they develop chronic pain. So if you've got people with pain, there's a lot of things that go into pain. People are often fearful and anxious about that pain. Pain is often coupled with movement, and so if you're fearful and anxious about movement, then you'll do less of it. And that can make the system more sensitive and push someone towards potentially developing a chronic pain state. So education like this can be very powerful, along with movement and exercise, in terms of helping people combat against that pain, sort of come up against it and not let it overcome them, and also sort of help them have a reduced likelihood of developing chronic pain. So all right, well, let's jump into it. So this is going to be the first of 3 parts. I tried to cut these down so they weren't as long as my biomechanics lectures, which some of those were an hour. So we'll try to do each of these maybe in 20 minutes or something, a little better bite-sized chunks. So when we think about just definitions of pain, from the International Association of Study for Pain, this definition was actually just slightly tweaked in 2020. It hadn't been changed since the late 70s. So the definition is pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Now, I know that's kind of a mouthful, but I underline some of the key points in this, that it has a sensory component, which we think about, with our different, sensory neurons in our tissues, vision, hearing, all of our different senses we could have that tell us about the environment, what's going on with our body, and an emotional side. And I think that's a huge part for people to think about, and we'll talk about this more in a little bit, but we have different inputs into our nervous system, and emotions are definitely an input, stress, things like that, and that can influence our experience. And then another really important part, actual or potential tissue damage. So of course we can think of situations where we have actual tissue damage. You sprain your ankle, you stretch or tear some of the ligaments in your ankle, and that causes pain. But we also have situations where people have pain from potential tissue damage. So their brain, they think something bad is going to happen or they're going to experience a tissue injury and end up having pain, but there was no tissue injury. So it was the potential for damage, and that caused pain. The brain produced pain to protect them, right? And then we've also got situations where people do have an actual injury or actual tissue damage but don't have pain. So a big part of this introduction to pain is going to be separating pain from injury. While they can go together, and often do, they are different things, and we can have tissue injury without pain, and we can have pain without tissue injury, and so important to kind of tease those things apart. So pain is unpleasant, but it's really important. We think of it as a danger alarm. It tells us when something is going wrong, potentially going wrong with our body. Again, actual or potential tissue damage. So it lets us know it's a survival mechanism, really. It's important. There are actually people who are born without the ability to experience pain, and often they end up dying earlier because they have fractures or infections, things where pain would have been really helpful to tell them something's wrong, but they don't have that, and so they go on about their life not knowing that something sinister is going on. And cancer, for instance, like cancer creates pain in many cases. So if you don't experience pain, it can be really dangerous. So it's an important alarm. So pain ultimately is experienced when the brain thinks an individual is in danger, and this has really been a major part of what's changed in the pain research in the last 10 years, 15 years, is thinking less about pain coming from the tissues of our body and actually an experience that our brain creates to protect us. So again, the pain is produced if the brain believes that there's actual or potential tissue damage, there's some danger. So again, we don't have to actually have an injury or tissue damage to have pain. It's just our situations where the brain thinks there could be a danger and will produce that pain. And I'll show some studies later where they actually manipulated this and were able to create different types of pain experiences in people even when there was no tissue damage, but they made them believe there'd be tissue damage. So just some kind of definitions there about pain. Pain is normal. This is really important to know, kind of leading off from that last bit about pain being important for our survival. Pain is a normal human experience, really important for us, staying healthy and just staying alive, an important survival mechanism. It's our most powerful protective device. But living in constant pain is not normal, and this is what we see so much of these days, where we see people developing chronic or persistent pain states. And as you can see, this stat, approximately 20% of people have pain that's persisted for more than 3 months. And if you look at the definition of chronic pain, that it tends to be, there's lots of factors and variables that go into it, but the time span that someone's had pain is one of those. And so you'll see if pain has persisted beyond 3 to 6 months, then it will start to get kind of grouped into this chronic pain or persistent pain category. And so, of course, people can have pain that long if they have an injury. Some injuries take longer to heal, or maybe you keep flaring them up. Like maybe you have a meniscus tear, and we know the meniscus can take a long time to heal. Maybe you keep participating in activities that are causing it to flare up and be painful. Some of those injuries can go on for up to a year, So having pain go a long period of time doesn't necessarily mean that it's a chronic pain condition, but this is one of the variables. So as pain goes on longer, it tends to be a poorer and poorer indicator of what's going on with the tissues of our body. And we see that if pain lasts, the longer it lasts, like I say, it becomes less helpful. So it can start to change, it can start to spread. Essentially, that danger alarm isn't really helpful anymore. So, a big part of what we want to do, again, with this type of education is to catch people early in the pain process, help to debunk any myths they might have about pain, reduce anxiety and fear, and hopefully prevent them from developing some sort of chronic, constant pain condition. So, of the top 10 most burdensome health issues of our time, chronic pain occupy the first, fourth, and eighth positions. You can imagine, of course, low back pain is the major one. Up to 80% of people have low back pain at some point in their lives, and spine pain in particular, from a musculoskeletal standpoint, can be really tricky. So many of those people particularly become fearful and anxious about using their back. You see this in the neck too. We see things like, a lack of sleep associated with these things, stress at work, in their life. There's all these other factors that can push people with spine pain in particular to developing chronic low back pain and chronic neck pain. So again, just something we want to be thinking about. It's a major issue in society, and unfortunately the medical and rehab system, we often don't do a great job of treating people with chronic and persistent pain. Partly, I think, because we don't have clinics set up that are holistic in nature, where we're looking at how the person thinks, their emotions, how they move, all of these factors. So we see more clinics coming about like that in the world, but still we need, many more. So looking just a bit about the history of pain, if we look at where pain started, René Descartes was a French philosopher who invented this thing called the mind-body split, where essentially, initially it was thought that the mind and the body were sort of separate things, and we know nowadays there's so much talk about how connected our mind and body is, things like our gut microbiome and our stomach and how that influences our brain. We'll look at this here and how much pain the body and the brain are tied together. So an older way of looking at this, and it might seem silly nowadays because we talk about this so much, but this is where it started. And so it was this idea that the mind was different from the body. And obviously today we know that doesn't exist, but we still see many pain treatments that are still based on this idea, especially pain treatments that really focus on treating only the tissues of the body. And again, there can be a place for that in many cases, but there's often too much focus on that, on the tissues of the body, and not considering other elements about the person that could be associated with their pain experience, especially when we look at people who have chronic or persistent pain states. So this, I like this image. It's a common one you've probably seen before if you've studied pain at all, but kind of contrasts the older pain sort of concept here, where we have something like a fire here, a thermal stimulus that would damage tissue, would burn us, and probably cause pain. But in the older models where there was a mind-body split, we thought of pain as this sort of one-way track where you would have an injury, something happens in your body, pain messages, we have pain receptors, and then a pain message travels up and tells us in our brain that there's pain. Now we know that's not true, it's not that simple. Now we know that we have this two-way system where we have a noxious stimulus or a dangerous stimulus, and that activates receptors in our body called nociceptors. A message travels up, that danger message travels up our spinal cord to our brain, and then we have all these things that our brain considers. Not only the sensory information coming from our tissues, but our mood, anxiety, depression, our expectations of what might happen, what the situation means, prior experiences, genetic factors, sensitization. Our system can be ramped up and be a little more sensitive. So all these things are going on, and then if the brain decides that this is dangerous and could create some tissue damage, then we can output pain. And so that pain would then be outputted via these descending tracks, so down through the spinal cord. And so we have this illusion of pain that's created by the brain. So this really helps us understand this mind-body connection. It isn't just the body sending pain messages. we really have something dangerous happening, we have danger or nociceptive messages. The brain evaluates the whole situation and then decides whether or not pain would be appropriate. Okay, so just kind of from historically how pain was thought about to where we are today. So when we look at modern pain science, as I said before, we see these increasing pain rates, and much of this, much of the reason we probably don't do a great job in the medical and rehab worlds, again, is because we focus too much on the tissues of the body. Most tissues, if you look at most tissues in the body, they're going to heal between 3 to 6 months, which is why if pain goes beyond that time frame, we start to think about it as maybe a chronic pain state. So we've got to remember that even if somebody's had an injury, most injuries are going to heal in 3 to 6 months, depending on the blood supply, the grade of the injury, things like that. So as the research has changed and we're looking at how pain, just this modern pain science, we really see that, as the research is changing, we're examining the nervous and immune system, those systems more as the primary contributors to persistent pain. The nervous system and immune system really have even been linked together and referred to as the neuroimmune system because they're so closely linked in terms of looking at pain. So different pain scenarios we can look at here. Obviously pain can occur in situations of obvious tissue trauma. You sprain your ankle, different like ligament sprains, you slip and fall and catch yourself and twist your knee and then you have pain and swelling. You can think of situations obviously where there's a tissue trauma and that causes pain, and that is very common, and that will be a place where examining the tissues really is important. But we can also have pain that emerges over time. Sustained postures, this is another change in the sort of the way we look at things in rehab. We don't think of postures so much as good or bad postures, but just how long have you been in a particular position. Oftentimes people have pain associated with sustained postures, being in a prolonged posture for a good length of time and not getting up and moving. The thing about pain that has gone, as pain goes on, even pains that start out, pain can be unpredictable and scare people. It can create fear and anxiety. You see this a lot in the clinic, especially pains that aren't as obvious to people or they don't know why they started. Pains that are deeper inside, we see this in the pain research that if somebody has a cut or a scrape on the skin that you can see visually, people tend to experience less pain with those because they can identify what's causing the pain. But when pain is deeper inside, say that's in a joint, say somebody's got a labral tear in their shoulder or something like that, or a ligament tear, they can't see what's happening, but they have pain. Those things often create fear and anxiety. Low back pain is a good example. Your low back, your structures are so deep, you can't see swelling or, there's no real signs of anything going on. You just have this pain symptom and you don't know why it's happening, and that can create fear and anxiety. And so again, a big part of this, the education piece, helping people kind of understand the intricacies of pain. So we look at the pain experience. Again, pain can be related to obvious insults, burns, sprains, strains, things we treat a lot in PT, bites. Obviously, these things all have a tissue injury, and the pain experience will vary, right? Like people with the same type of injury are going to have different types of pain experiences. The pain experience is really unique to you. It's almost like a fingerprint. We'll talk about this a little later when we look at the brain and sort of how different neurons fire, but it really is a unique thing, almost like a fingerprint. Pain is, is more complex, highly influenced by our thoughts and emotions, how we think about pain, how we were raised, how our parents responded to pain or when we got injured. There's all kinds of things that go into this in terms of how the pain we experience and the thoughts that we developed with our emotions. If people are really stressed out when they have an injury, that can alter the pain experience, maybe even contribute to them developing some sort of chronic pain state. If they were in a situation that was really stressful, maybe they had a really stressful job and they got injured, And that stress compounded with the injury heightens their pain experience. We see things like that. So in the cases where pain is, because again, pain can be unpredictable, if we see pain that spreads or lasts longer than that 3 to 6 month time period, we have to really understand the brain's role. We can't just be thinking about the tissues only anymore, because again, the tissues are going to pretty much heal, and there's a lot of people who go beyond that window and still have pain. So we've got to be thinking about these other factors that can influence pain, especially if we see that's lasting longer or it's spreading. People with chronic or persistent pain will say that it spreads, won't stay in the same area. It'll become more vague. The quality of the pain can change. We see all these types of changes when these changes are happening at the neuro and immune system level. So when we think about when you're thinking about pain from a more comprehensive standpoint, this Neuromatrix model is something I always like to show. Basically, you've got inputs here on the left, and then you've got outputs on the right. And you've got this body self neuromatrix in the middle that's sort of spinning. These inputs are coming in, so we've got cognitive related inputs like memories of past experiences, our attention to the situation, what it means to us, and we'll talk about that more later. It's a really important one. Any anxiety that we might have going into the situation. We've got emotions down here, emotional type factors, the emotions that are going on at the time, stress, again, maybe anxiety, depression, things like that. And then in the middle, we've got our sensory signaling system. And those are what us in the rehab world really think a lot about: musculoskeletal inputs, sensation from the skin, from our muscles, our fascia, our joints, all those things that are coming in from the sensory system. All of those inputs are going to come in and be sort of weighed together. And then, depending on what the brain perceives to be the right course of action, we could output pain. So that might be one of the outputs, pain perception. We could have an action program, like maybe we would move, right? Like if you think about touching a hot stove, when you touch it, you instantly draw back. So we could have an action program where our fingers touch something hot that's dangerous. Our brain perceives that that's going to be, could result in tissue damage. So we contract our elbow flexors quickly to pull away from that dangerous stimulus. And then we have stress regulation. So cortisol or different stress hormones, endorphins, immune system activity, all of these different outputs that can come from these inputs and how our brain sort of weighs the situation and decides what's appropriate. So I just like this one. It's a good way, I think, to put this all in one picture and think about all these factors and how they work together. So when we look at pain neurobiology, again, pain is this multi-dimensional experience. We think about all these inputs and factors that come in. And we talk about a neurosignature or neurotag, and this is what I was referring to earlier when I was talking about the fingerprint. So there are these patterns of nerve potentials in the brain, and this is really unique to each of us. Our pain experience is completely unique. This is why it's so important when people have pain to validate their symptoms and to listen to them and hear what's going on, because it really is totally unique to them. None of us can understand someone else's pain experience. We really have to, just listen to what they're saying and try to validate their symptoms and help them figure out a plan to move forward. But at one point in time, we thought that there was a pain center in the brain, sort of a dedicated pain center, and that's really been shown to not be true. There are multiple different centers in the brain that work together to create this pain experience. I mean, we've got everything from our occipital lobe, visual information coming in, all the information from touch in our body, our tissues is going to come in, our visual system, our experiences and memories. All these brain areas are going to work together to create this neurosignature pattern of nerve potentials when we output pain. So again, it's sort of like a fingerprint that's unique to us. They're generated by this body self neuromatrix that we looked at just a second ago. The brain again generates this experience of the body, including pain. So the brain generates these experiences. Sensory information, while it's important, it only really modulates this experience. So we have to remember, sensory information from our body doesn't create pain. It plays a role in modulating it. We would get danger messages, nociceptive messages from our body, and that will play a role in the pain experience, but it's just one piece of the puzzle. Okay, so just quickly, you want to talk here about 3 different pain types. If you look at pain types Online you'll see different types of breakdowns, but this is a fairly common one that you'll see. So one type is neuropathic pain, which refers to pain caused by a lesion or disease of the nervous system. So we might think about this with something like sciatica, right? Like if you have an injured or an irritated or injured nerve root in your low back or maybe your sciatic nerve, that can create pain associated with a lesion of the nervous system. Or if you hit your funny bone, that's considered an acute neuropathic pain. If you hit your ulnar nerve, you get those shooting, tingling, numbness type sensations. That's related to injury of a neuropathic structure. Diabetes also is. So you can have chronic neuropathic pain states where somebody has neuropathy because of diabetes. So that's one type. And then we've got sensitization, and this is often what's seen with chronic or persistent pain where pain's been there for a long time. We see that these nociceptive neurons that carry danger messages, they become more responsive, they become easier to turn on. And so you might have someone, in a healthy nervous system, you touch your skin and it just feels like you're touching your skin. You could have someone who has these nociceptive neurons have been sort of dialed up and they're ramped up and they get touched lightly and it creates pain. So we call that hyperalgesia and allodynia. It's when pain is created to a stimulus that's normally not painful. So that would be a sign of this sensitization process where we're seeing a pain experience from something that's a type of stimulus that's normally isn't dangerous and wouldn't normally create pain. So this increased activity in these nociceptive neurons takes a very small stimulus to turn them on. And then the third type here is nociceptive pain, and this is pain that is the most mechanical one in a way. It's pain that arises from actual or threatened damage to non-neural tissue. So these would be all of our other tissues like skin, muscle, fascia, bone, all those ligaments, tendons. All of these things are going to have nociceptors, which are these danger receptors, and if they are activated and the brain decides it's appropriate to output pain, then that would be more of a nociceptive pain. This is the area that's going to most closely fit with that sensory signaling system we just looked at in the neuromatrix. So when we think about afferent incoming sensory information from our tissues from the musculoskeletal system through this sensory signaling system, the nociceptive type pain is going to be the one that's most closely tied to those messages coming from our musculoskeletal tissues. So again, there are different breakdowns of pain out there, but these are three that you'll commonly see. Sometimes the sensitization category will just be chronic or persistent pain. So again, sometimes those are used interchangeably. Okay, just the last little bit here, I just want to talk a little bit more about nociception, this danger messaging process. So nociception, again, when our nociceptors, those danger receptors, are activated in our tissues, then a nociceptive message will travel up the spinal cord to the brain. So we're just going to look at this whole process. Basically, first we have this transduction process. So afferent nerve endings are nerve endings that carry messages towards our brain, away from our body towards our brain, up the spinal cord towards our brain. So first we have transduction. We take this dangerous stimulus, noxious stimuli, and that's transduced into nociceptive impulses. And those are carried by A delta and C fibers. These are types of nerve fibers. Okay, so first we transduce that stimuli into impulses, and then we transmit it. So transmission, this neural signal is carried to the dorsal horn, which is part of the spinal cord, the back side of the spinal cord, and then it's going to go up ascending tracks in the spinal cord. And then we have modulation, so we can turn down these nociceptive messages or we can amplify them. And we'll look at that later. We even have built-in different neurotransmitters and hormones that can dampen or amplify these neural signals depending on the situation and what would be appropriate. So, for instance, if you sprain your ankle crossing the street, your brain might decide to turn down those nociceptive messages so that you can get out of the street and not get injured getting hit by a car or something. So we have different molecules that can either amplify or dampen these nociceptive messages. And then perception is the final stage. So this is the conscious awareness of pain based on sensory, cognitive, and emotional inputs, just like we saw in the Neuromatrix. All these different inputs that can come in that can be a part of the pain experience. Again, this is why we need to think about all these factors when people have pain. Not just their body and the sensory inputs, but what do they think about pain? What are the emotions going on associated with it? We need to listen and pay attention to all of these and help them be in tune with all of them. So again, like I said in the beginning, injury and nociception are distinct, as well as nociception and pain. These things are different, okay? So oftentimes people think that when they have pain, most people will think when they have pain they have an injury. And that definitely obviously can be the case, but like we've talked about, you can for sure have pain and not have an injury. You can have an injury and not have pain. You can have nociception, the activation of those danger receptors, and not have pain. The brain might decide we don't need pain. These nociceptors are activated, but it's not important. So these things are different from each other. They're distinct from each other. Injury does not necessarily imply that pain will be experienced. We have lots of cool studies, especially MRI studies, where we take people who we go and put them through an MRI. They're people who don't have pain, they're asymptomatic, and say you do low back and neck MRIs on people, a large percentage, up to around 40% of the population, have disc herniations, which is technically an injury. Many people would classify it as an injury, but they don't have pain. And we see this with things like meniscus tears, labral tears in the shoulder and hip. Oftentimes these injuries exist in people who don't have pain. So again, these things are different. You can have things that are technically categorized as injuries and not have pain. And then you have people like many low back pain people. Most low back pain is called non-specific, which means that if you go do an MRI, there's nothing on the MRI. It's clean, but the person still has pain. So it's so important to untangle these things for people and help them understand the differences, so that they can, again, help reduce that fear and anxiety, so that they can really focus on their symptoms, what triggers their symptoms, and what are they limited in terms of their function, and just help them overcome those things. Let's focus less on what's causing the pain, that there has to be some tissue to blame the pain on. And again, like I mentioned before, activation of nociceptors, these danger receptors, does not always mean that pain perception will occur. You could have nociceptors being activated all the time. You might be sitting in your chair for too long and activate nociceptors in your buttock region, and in most cases it will just kind of be a cue to us to move, but we won't experience pain. So many different situations where nociceptors can be activated, but the person doesn't feel pain. You hear of more traumatic ones where people have severe injuries where nociceptors definitely should have been activated, but they didn't experience pain when it happened. So lots of interesting examples out there, and really a big reason why a lot of this research started. So last, just want to end with this last slide on nociception and pain. This is another sentence here from the International Association for the Study of Pain. Basically, pain and nociception are different phenomena. Pain cannot be inferred solely from the activity in sensory neurons. And just to bring this home, just a little kind of joke thing here from The Simpsons, I will not equate nociception with pain. So important to know that these things are different. Danger messages do not always lead to pain, and I really like this last sentence here. Pain cannot be inferred solely from activity in sensory neurons. Again, this is how most people treat pain. They think it's related to what's going on in our tissues and what's being transmitted through those sensory neurons, and that is not the only part of the puzzle. It's much more complicated. We've really got to think about this from a biopsychosocial standpoint and examine these other factors that might be going on in our lives or in the person's life that we're working with. So, all right, you guys, this is the first part here. I hope you're enjoying it so far. I'm going to have 2 more parts to the pain, kind of introduction to pain here. So stay tuned for those, and I will see you soon. Bye.